So we have a great opportunity here today with the Rocky Mountain Lions Eye Bank coming to do a wet lab. It's pretty unique to have the real tissue as well as human corneal scleral rims on an artificial chamber, which gives a really accurate way of injecting the tissue and unfolding it. And so this lecture is not meant to be comprehensive, but just kind of a quick introduction to why we're doing DMEK and what we're doing in the wet lab today. So there's a lot of letter salad with corneal transplants these days. They all have EK in them when it's replacing the endothelium. So the endothelium can be damaged in Fuchs, pseudophakic bullous keratopathy, and CHED, or congenital disease. Historically, we've done DSEK, which had some tissue from the stroma as well as the decimase endothelium, replacing the endothelium, and then more now DMEK, which is the decimase membrane endothelial keratoplasty, which is a one-to-one replacement of the damaged endothelial cells, and the cells are carried on the decimase. So I think this is best seen anatomically. This is an anterior segment OCT on top showing the DSEK, where you can see the DSEK graft with the stroma underneath the natural cornea, and below that a DMEK, where the decimase is so thin you can't even really see it on the anterior segment OCT. Basically, it looks like a normal cornea. This would be indistinguishable from a normal cornea. And I found this picture on the internet. But then on Tuesday, right before I came up here, I had one of my own patients that had a DSEK on the right eye, which is on the top. And this is a ultra-thin DSEK. It's only about 50 microns thick. It's about as thick as the epithelium. And then below is his left eye that was done 3 years later with the DMEK, giving slightly better vision. He's about 20/25 in the right eye and 20/20 in the left eye in the bottom. So why do DMEK? Basically, it's just better in pretty much every metric. So patients have better visual acuity. As long as the eyes are normal, they're pretty much all near 20/20. The rejection rate has been shown to be about 10-fold less, or less than 1%, which is amazing. And faster visual recovery. The studies of DSEK, people are better at year 1, then 2, then 3, then year 4 and 5. So it takes years really to get to the best function, whereas the DMEK, within a month typically, most of them are at their final visual acuity. So why start it now? It's really just an amazing time to get started compared to when I was a fellow in 2012, because all the kinks have finally been worked out. And so the kinks originally were graft preparation. You had to do it yourself, which if you lose the graft, then you just lose that, and you basically the center loses the money. And then unfolding techniques hadn't really been worked out, and so people had a hard time getting it unfolded. And no one knew which way it was up or down easily because there was no stamps showing an orientation at that time. But now you can get the tissue pre-punched to whatever size you like. Most people use 7.5 or 8, pre-stained, preloaded with the S stamp. And so basically it's just read like an IOL, preloaded, ready to inject into the eye, saving all the time and stress of having to do that. Also, there's extensive videos online. So it's this is how I learned, just watching video after video to learn all the unfolding techniques. And the local eye banks will happily host you, often at no cost to you, to learn how to do this in a human globe or the artificial anterior chamber. So why don't people do this? Basically, I think still about half the EKs are done or DSEK when they could have been DMEK. It is a little more challenging technically, and people get comfortable with prior techniques. Some people are still doing PK for Fuchs, which is too bad in this time. The key thing is, first case is just get a totally normal eye with a clear cornea. You don't want a bunch of arcus or edema to block your view. You want a normal segment. You don't want it too shallow or too deep. It can be phakic or pseudophakic. It's actually often easier with the phakic eye because it's easier to shallow the chamber with the lens in place. Dark colored irises are tough. I really struggled on a couple African American patients seeing, just because it's with the blue graft on top of the dark iris. It's just hard to see. It's almost impossible to unroll a DMEK graft with vitrectomy, and they don't stick as well with low pressures if you've had a trab or a tube. And then you do need a PI to not have pupillary block, and so a PI with a laser 6 o'clock is nice because they won't have any bleeding. So why do the lab? Basically, is to learn how to handle the tissue outside of the eye, lifting it up, inserting it into the inserter. Then it's good practice. You can also insert it and do the DMEK dance to unfold. So today, like I said, we'll be doing an artificial chamber with a human corneal scleral rim to mimic the anterior chamber. And this gives you a good chance to practice that. I learned on the whole globes, which are very variable because often the cornea is cloudy, or the iris is releasing pigment everywhere, or the chamber is hard to get, or the eye is deflated. And so I think this is a great way to maintain a nice stable chamber the whole time. And so we could have had preloaded tissue today, but we won't have that. We'll just have tissue that you'll load yourself, but it's good in case you ever have a graft ejection to reload it yourself to know how to do that. Basically, the incisions, I took this from Michael Stryko, but Basically, for a DMEK, you'll make these incisions. We'll have a 3mm incision temporarily or in front of you, and then 2 paracenteses for cannulas to manipulate the graft with air and fluid. So I'm just going to show one video just of basically how this works with the artificial anterior chamber. This is Chris Salas, who trained with Mark Terry. His video here.
This is Chris Salas. I'd like to share with you a short video about how the DMEK stage can help you simulate DMEK surgery in the wet lab. Here the anterior chamber is deep, which can be visualized by looking at the blue that's showing through the latex diaphragm because it's in contact with the artificial anterior chamber. When the anterior chamber is shallowed, volume and pressure is released from the anterior chamber, which allows the latex diaphragm to come forward off of the artificial anterior chamber. The bubble, in turn, also becomes larger because it's pressed up against the cornea in a shallower anterior chamber. Injecting air into the artificial anterior chamber increases the pressure and volume of the posterior segment, which pushes the latex diaphragm forward and further shallows the anterior chamber. This makes the bubble in the anterior chamber appear to get larger. With the anterior chamber now shallow but pressurized, the residual bubble can be burped from one of the paracentesis incisions. The anterior chamber can then be deepened again by injecting BSS through one of the paracentesis incisions. When this is done, the pressure of the anterior chamber exceeds the pressure of the posterior segment. The interplay of pressure and volume between the anterior chamber and the posterior segment can be seen with tissue injection. Here, the tissue is injected and volume of the anterior chamber is increasing, which is why you see the latex diaphragm bulge posteriorly and come into contact with the blue surface of the artificial anterior chamber. When the paracentesis incision is burped, volume and pressure is released from the anterior chamber, which brings the latex diaphragm off of the artificial anterior chamber, making it white again. Further injection of fluid into the anterior chamber deepens the anterior chamber once more, and release of BSS from the anterior chamber shallows the anterior chamber again and lowers the pressure in preparation for removal of the injector. Now let's look at what kind of dance moves you can do on the DMEK practice dance stage. You can do the cha-cha shuffle. You can do the touch and release. And then you can open the graft upside down and flip the graft over. You can then shallow the chamber and do the flick. And of course you can do the gyrosome. And the golf stroke. And the bubble. Thanks for watching. Really hope this helps.
So I'll stop here in the interest of time, but I think we do have some extra slots for DMEK if people want to do it. Basically, we're doing 30-minute slots, but it's a great chance to practice, and if you want to try it, just go on over to the Rocky Mountain Lions IBEG station and put down your name, and we can get that done. Thank you.